Alright guys, now let's move on to heart failure. First, let's make sure that we understand that heart failure is not a disease. It is a clinical syndrome that is the end result of cardiac pump dysfunction leading to congestion and low perfusion of systemic organs. There are two mechanisms by which reduced cardiac output and then heart failure can occur: systolic or diastolic dysfunction. Let's start with systolic dysfunction. Systolic dysfunction usually occurs from multiple infarctions, decreasing the number of myocytes capable of contracting, leading to decreased left ventricular contractility. This means that the ventricle cannot pump a sufficient amount of blood into the aorta. This drop in our stroke volume will increase the residual volume in the chamber, increasing our end diastolic volume, and also dropping our ejection fraction, and subsequently our cardiac output. The congestion of blood will back up from the left ventricle into the left atrium and into the lungs. This will cause pulmonary venous congestion. This backup of blood also increases the pressure in the pulmonary vasculature. This subjects the right ventricle to higher pressures than it is accustomed to pumping against. Eventually, the right heart will have a ton of difficulty pumping forward, and we get a decrease in right ventricular output. Now there's going to be backup of blood and subsequent congestion of the systemic veins, and this is how we get peripheral edema and the other signs of venous congestion such as JVD, jugular venous distension. The second way to get to heart failure is diastolic dysfunction. Now diastolic dysfunction is tricky because the problem isn't with volume. The ejection fraction and the end diastolic volume are the same that you would expect in a normal healthy patient. The problem is that we have a decrease in compliance. This means that the ventricle is stiff, and for a given amount of volume that you put in that ventricle, you're going to require more pressure to fill it in diastole. So we need more pressure. Increased left ventricular pressure is then going to be transmitted retrograde into the left atrium and then into the lungs. This increase in pressure of the pulmonary vasculature can lead to pulmonary venous congestion. Now, why is this a problem? Again, we're going to increase the afterload for the right ventricle. Eventually, it's going to give out and we'll have decreased right ventricular output. Now we have the same situation in which we get systemic venous congestion, and we can get things such as peripheral edema and JVD. Now, how does diastolic dysfunction lead to decreased contractility and cardiac output if we said that ejection fraction and end diastolic volume are the same? Problem is that this won't last for long. The hypertrophic myocardium is susceptible to ischemia because there's so much mass that needs oxygen. These patients are eventually going to have infarcts and lose myocardium. Now they're going to be in the position where they're going to be having decreased in left ventricular contractility. So both systolic and diastolic dysfunction eventually lead you to full-blown heart failure. Now let's discuss the compensatory mechanisms associated with heart failure also in this diagram. The problem is a decrease in left ventricular contractility leading to a drop in cardiac output. Now, the baroreceptors in the aortic arch and the carotid body detect this. They activate the sympathetic response and hope to stimulate that left ventricle to contract more. Remember, the beta receptors on myocytes can increase intracellular calcium in order to increase heart rate and contractility. Alpha adrenergic vasoconstriction can help increase the preload by returning more blood to the heart. Now, beta receptors on the JG cells, the juxtaglomerular cells of the juxtaglomerular apparatus, also respond to catecholamines. In addition, the afferent arteriole senses hypoperfusion. This combination ramps up the renin-angiotensin-aldosterone system. Activation of this system leads to aldosterone-mediated increase in sodium retention and therefore water retention. This increases intravascular volume. We want to increase systemic venous pressures. This actually can lead to problems. So what we do is we target our drug therapy towards these compensatory mechanisms. We use ACE inhibitors and aldosterone antagonists to target the renin-angiotensin-aldosterone system. Spironolactone is the prototypical aldosterone antagonist. Beta blockers are used to oppose the chronic sympathetic activation on the heart and the JG cells of the kidney. What else can we do to make it easier for these patients' hearts? We can give them hydralazine. This helps decrease the afterload and hopefully increase cardiac output. It is important to understand that giving patients something like a thiazide or a loop diuretic is only for symptomatic relief. When a patient has too much fluid in their lungs or the interstitial tissues, they do not change mortality. Alright, now let's talk about left heart failure. Left heart failure leads to the backup of pressure and volume into the left atrium and the pulmonary vasculature. This elevated pressure in the pulmonary veins and the pulmonary arteries leads to pulmonary vascular distension, and eventually the stalling forces in the capillaries favor fluid movement across the vessel into the alveoli. This is how these patients get pulmonary edema. We can really appreciate that here in this image. The fluid in the alveoli shows up on X-ray as very dense, opaque nodules that you can see everywhere diffusely in this person's radiograph. Another image that you could be tested on is something like this. Now, what are these? Eventually, blood can also leak across the pulmonary vessels directly into the alveoli. This is the alveoli here. Now, alveolar macrophages will start to consume red blood cells. The alveolar macrophages take the hemoglobin and break it down. The iron from the hemoglobin is going to be stored as hemosiderin. That gives us this thing a very nice brown color from the hemosiderin deposition. We're looking at heart failure cells, also called hemosiderin-laden macrophages. That's a cool sign of pulmonary congestion, but no way that we're going to be taking pieces out of our patient's lungs if we suspect heart failure. We need to be confident in our physical exam skills. What are some physical symptoms your patient is going to be telling you about? How about orthopnea and paroxysmal nocturnal dyspnea? No way these words are going to be on the exam. You need to be able to understand the physical exam's findings and how they will be described to you. So first of all, orthopnea is Greek for straight, and then apnea is Greek for breath. So this is shortness of breath that occurs when a patient is laying straight on their back or supine. When laying flat, there's an increase in venous return to the heart because there is no more gravity to fight against the venous return from the lower extremities, from the legs. These patients end up sleeping with several pillows at night to prevent from being completely flat or supine. That is why sometimes this is called pillow orthopnea. Now, paroxysmal nocturnal dyspnea is like a delayed form of orthopnea. Paroxysmal means sudden attack. Nocturnal means at night, and dyspnea means the sensation of being short of breath. So while patients are sleeping, fluid is gradually returning from the interstitium back into the veins because there is less hydrostatic pressure due to the absence of gravity. Now eventually, what are they going to do? They're going to pop up from sleep, gasping for air because the increase in fluid return has overwhelmed the pulmonary vasculature. This is why we need to be concerned about the very high pressures in the pulmonary vasculature, in addition to the effects that it's going to have on the right side of the heart. Alright guys, now let's resume talking about heart failure, specifically right heart failure. What's going to happen is that the right heart is going to hypertrophy in an attempt to pump against the elevated pressures in the pulmonary vasculature. Whether this is due to left heart failure or cor pulmonale, eventually pumping against this elevated pressure will lead to one day when the right ventricle begins to fail. And the venous blood will start to accumulate in the right ventricle, and it'll back up into the right atrium, into the superior vena cava, inferior vena cava, and then eventually into the jugular veins. And we can actually see the pulsations of the external jugular vein on physical examination. In addition, we can also see other things such as peripheral pitting edema, as we can see here in the lower extremity. An increase in the intravenous pressure, particularly in gravity-dependent areas such as the lower extremities, will lead to edema due to the transitation of fluid across the capillary vessel wall. Now, an increase in venous pressure within the hepatic vein will cause hepatic hypertension. When blood cannot accumulate in the liver and there is high pressures, the chronic congestion will actually lead to a nutmeg liver. We can see that here in this image. The pressure causes blood to leak into the sinusoids. It's like the liver is bleeding into the spaces around the engorged sinusoidal veins. It kind of looks like a nutmeg cut in half. The dark yellow areas correspond to fatty change. Now, chronic congestion can lead to fibrosis because the stellate cells that are present in the sinusoids will be activated to deposit collagen.